Start ചെയ്തിട്ട് മീൻസ് മീറ്റിംഗ് സ്റ്റാർട്ട് ചെയ്തിട്ട് ചെയ്താൽ മതി.
So welcome everyone to the second monthly academic series. So today we have a very important person, a very renowned doctor. So before we enter into the new session, I would like to invite every one of you who have joined in, and I kindly request all of you to let your friends also know that we have very informative sessions coming up in AFPI academic series. Firstly, let me welcome Dr. Prashop, the AFPI President North Zone, to give the welcome address.
Hi, good evening all. I'm Dr. Prashop, AFPI Kerala North Zone President. Last month we did an excellent topic regarding diabetic nephropathy. This time it's regarding rheumatology topic. So regarding arthritis, is the best person to talk is a rheumatologist. So we have Dr. Adarsh MB. He's actually my classmate also. He did MBBS from Calicut Medical College, MD from AIMS New Delhi, and DM from PGA. So I know he's a very excellent speaker. So he's the chief guest and speaker of our this session. So next is to moderate this session, we have Dr. Anand. There is no introduction for him. He's all in AFPA. He's the founder member, past president of AFPA North Zone, and state committee member also. So on behalf of AFPA North Zone, I am gladly welcome Dr. Adarsh MB and Dr. Anand to start this session. And it will be, I'm sure it will be an excellent informative sessions for both practicing physicians as well as PG students. I think there is whole India participation. So I'm welcoming you, all the participants for this session. So we can.
Thank you, Dr. Prashop. I think we'll move ahead. We all know that rheumatology is a subspecialty in internal medicine and pediatrics that deals with joints, soft tissues, inflammatory conditions, and autoimmune diseases and other heritable connective tissue disorders. And these conditions are being increasingly diagnosed these days because of increasing awareness amongst physicians, as well as increasing modalities for better diagnostic tools. So joint pains are a common presentation in family practice, both acute as well as chronic. So it is imperative that we are familiar with the systematic approach to such joint pains, so that we can alleviate the symptoms as well as come to a diagnosis quickly in a very scientific way. So today we have with us Dr. Adarsh MB, who is working as an assistant professor in the Department of General Medicine at Government Medical College, Calicut. So over to you, Dr. Adarsh, for the session.
Am I audible?
Yes.
Hello?
Yes, you're audible.
At the outset, I would like to thank the organizing committee and the members of AFPI for inviting me for this talk. And so without much introduction, we'll start the session. The topic is approach to joint pain. So joint pain is a very common thing, and we see in and out in our OPD days. So a stepwise approach to joint pains will help us in getting a better diagnosis, to assess the disease, and to avoid multiple investigations. Actually, that's the most important thing, rather than going for a multiple investigations at the first point itself. If we go for focused investigations, that will help the patient as well as the physicians. So we'll start. So a joint means we have a bony component the bony surface is covered by a cartilage, and the cartilage has an cartilage is covered by a synovial lining. The synovial lining is the one which produces the synovial fluid, and it has a capsule covered by a capsule, and over the capsule we have tendinomuscular structures as well as the neurovascular bundles. So everything together makes the joint. In inflammatory arthritis, what happens is there is an inflammation ongoing. There will be synovial hypertrophy as well as inflammatory infiltrates, which will cause a secretion of synovial hypertrophy as well as secretion of synovial fluid into the joint. And these inflammatory markers as well as the inflammatory fluid itself will cause pain. So that is the most common cause for pain in arthritis. So how do we approach? There are 6 key questions we have to ask ourselves when a patient comes with multi-joint pains. So these are the 6 steps of the approach. We'll go one by one. The first and foremost question is the pain articular or is it a non-articular? So as I told, the bone, the cartilage, the synovial tissue, and the capsule makes the bone, cartilage, the synovial tissue, and the capsule makes the joint. And whatever outside it, which includes the muscular structures as well as the neurovascular bundles, makes the extra articular substances. So take a patient with a shoulder pain. So the shoulder pain, I will just demonstrate 2 conditions. First one is an osteoarthritis or an inflammatory arthritis of the like a rheumatoid arthritis of the shoulder. The second thing is a supraspinatus tendinosis. So here we have to determine the first one where the joint itself is involved, and the second one the extra joint structure is involved, which is the supraspinatus tendon. So how do we recognize that it is an articular pain? In articular pain, because the joint surface per se is involved, the pain will be throughout the range of motion. So you abduct the shoulder, you flex the shoulder, extend the shoulder, the pain will be there. It will be painful, both active movements when we ask the patient to do it, or we ourselves move the joint. But take in a case of supraspinatus tendinosis. Here, pain will be more when the supraspinatus tendon is contracted. So if we ask the patient to abduct, there will be pain, but it will not be painful when we ask the patient to do a flexion or an internal rotation or external rotation. To some extent, there will be pain, but the pain will be maximum when we are asking the patient to abduct. Also, when there is a painful structure like a supraspinatus tendinosis, the active movement, when we make the supraspinatus muscle contract, that will be more painful. But if you do a passive abduction, where supraspinatus tendon is not contracting per se, the pain will be less. So in arthritis, the range of motion, all the range of motion will be painful, both in active and passive. But if it is an extra articular tissue which is involved, most commonly a tendon or a muscle tissue, the pain will be more in active contraction, and it won't be painful in all the range of motion. Only in the direction of the affected muscle will be painful. So because almost all the articular surface is involved, there will be symmetrical restriction of range of motion. And when we examine, the tenderness will be along the joint line. So in supraspinatus tendinosis, the tenderness will be along the supraspinatus tendon. But in an OA of the shoulder, you will have pain along the joint line. Also, because the diffuse process, it involves a diffuse process, the swelling will be diffuse. You can see an anterior bulge, and you can have the diffuse swelling of the joint. See, if it's a knee joint, there will be diffuse knee joint swelling. But if it is a supraspinatus tendinosis, the swelling will be along, the effusion will be along the supraspinatus tendon, or if it is a bursitis, that bursa will be, if you say suprapatellar bursitis as a cause of knee pain, there will be the bursitis part only will be swollen. Suprapatellar bursa will be swollen. Rest of the joint will be normal. And the presence of a crepitus, which means the bony surface is involved, also suggests that it is more likely an articular one. And most often joint deformities comes with the articular involvement. When there is arthritis and articular involvement, most often lead on to the classical deformities. And if we go for special tests for the specific muscles, like if you go for pain on the painful arc in a supraspinal tendon, or if you go for any of those muscle testing for subscapularis or latissimus dorsi, that will be more specifically positive in a case where extra-articular things are involved. So that's how we differentiate between the first and foremost is it articular? Then only we can call it as arthritis. So is it arthritis? Is it the joint structure, joint is involved, or is it an extra-articular? That is most often it is a clinical diagnosis. So once we diagnose it as an articular pain, the second question is, so here is an example for deformity. So either you can see the classical swan neck deformity as well as boutonniere deformity. So these deformities arise due to the structural damage that occurs in the joint. So it means the joint is per se is involved, not just the extra joint structures like a bursa or a tendon is involved. So presence of deformities usually suggests that the involvement is articular or it is arthritis. So once we identify it as an articular problem or related to joint or an arthritis, the second key question is it an inflammatory thing or is it a non-inflammatory thing? So what are the characteristics of an inflammatory joint pain? We all know the classic symptom is morning stiffness. Usually there will be a prolonged morning stiffness, usually more than 30 minutes. The patient has maximum problems when the patient's rest. So resting pain will be more prominent and the pain will improve once the patient starts using. While non-inflammatory, classical non-inflammatory arthritis is osteoarthritis. So the pain worsens when the patient moves or uses the joint, but it improves when the patient rests. And presence of instability features or locking or unlocking, it more often suggests an internal joint derangement, which is more often associated with a non-inflammatory, like a post-trauma, ACL tear, or a loose body within that due to an osteoarthritis, loose body within that. So those things suggest that it is more likely a non-inflammatory thing. And the telltale signs of inflammation, like Ruber-Kaller-Dollar thing, when there is a swelling, diffuse swelling associated with a significant tenderness, local rise of arm and a red swollen joint. So these are more classically seen in inflammatory thing. So classically, presence of morning stiffness, improvement worsens with rest, improves with exercise or use, and presence of additional features of inflammation suggests that it's an inflammatory joint. So first is joint, then is it inflammatory, yeah, or non-inflammatory? The next question to ask is, there are some classic non-inflammatory pain differential diagnosis. So classical inflammatory is rheumatoid arthritis or any things like that. So there are non-inflammatory joint pains which include osteoarthritis, which includes sports trauma injuries like ACL tear or an meniscal tear. One important thing is fibromyalgia, where you have diffuse widespread pain, which also involves joints and non-joint pain. Benign joint hypermobility. Presence of joint hypermobility itself can cause significant peri-joint pains. Presence of intra-articular loose bodies, avascular necrosis as in steroid use or alcoholism. Then bleeding into the joint as in bleeding disorders, hemarthrosis. And in diabetic, when you have a significant neuropathic joint or a Charcot joint, these are all non-inflammatory joint pain, and this is how we differentiate it from inflammatory thing. Because if it is an inflammatory pain, you need to include things that can subside the inflammation. But if you add like steroids or disease-modifying agents, but in non-inflammatory joint pain, we don't have to start these things, and maybe even counterproductive if we start steroid or disease-modifying agents in such things. So most important step in joint pains assessment is to recognize it as an inflammatory or a non-inflammatory pain. This is the most important thing. So here is a normal joint and then osteoarthritis, which is the classical non-inflammatory thing. So where the synovial hypertrophy is not that significant when compared to rheumatoid arthritis, where it's an inflammatory pannus formation and significant synovial inflammation. But here it will be cartilaginous and joint space reduction, whereas here it is more of a pannus and synovial hypertrophy, synovial effusion, more like that. And next question is, okay, we have an inflammatory joint, so we need to know whether it is an acute event or a chronic event. Usual acute, the time duration which is taken is 6 weeks. If the duration is less than 6 weeks, it is taken as acute, and if it is more than 6 weeks, it's taken as chronic. So there are some specific things like a viral arthritis, chikungunya arthritis, or any infectious mononucleosis, some of the viral or parvo B19 infection. So these things can cause viral arthritis, and usually they are self-limiting. We have to identify it as many of the acute things are self-limiting. Septic arthritis, not just the viral arthritis are self-limiting. So septic arthritis, usually short duration illness, crystal disease like gout, or acute rheumatic fever. Then even the it may be a first presentation of a chronic arthritis like rheumatoid arthritis. Patient may be symptomatic for last 4 weeks, but it may be the first symptom of a rheumatoid arthritis. So we need to classify it as a chronic. The more chronic it becomes, the more likely that it needs disease modifying agents. Even in short duration illness, like most likely post-viral arthritis or viral arthritis, you may wait for it to subside by its natural course. So the next important question is, what is the pattern of joint involvement? We have to identify. Arthritis is predominantly a pattern recognition. So we need to recognize in which pattern the joints are involved. That will help us to make a reasonable diagnosis from the clinical history and examination itself. So within the pattern, the main thing is it an RA pattern of illness or is it a spondyloarthritis pattern of illness? So rheumatoid arthritis, you get symmetrical small joint predominant, upper limb and lower limb distal involvement. So you will have metacarpophalangeal, first MCPs, then you have tarsal joints, intertarsal joint, wrist joint involvement. Predominantly involves the distal joints, involves the small joints, classically spares the distal interphalangeal joint, and usually it will have a additive way of progression. Like it will come on the wrist, then next wrist will be involved, the carpals will be involved, then ankles, knees, like that. So rheumatoid arthritis pattern is an additive polyarticular involvement, which is most often symmetrical, involving the small joint, predominantly upper limb, without axial involvement. Axial involvement is axial spine involvement, like inflammatory back pain. So presence of inflammatory back pain involving the large joints like knees, shoulders, elbows in an asymmetrical pattern, involving the predominantly lower limb involvement. That is what is seen in spondyloarthritis. It is not that RA will have large joint involvement. It's not like that. I'm just saying about the pattern of involvement. So RA pattern is additive, will be symmetrical, predominantly small joint upper limb involvement without axial involvement. Right? Spondyloarthritis, you think about reactive arthritis. So where there will be a large joint involvement, predominantly the lower limb, like hips and knees and ankles. And upper limb involvement will be less often when compared to that. Also, they will have spondyloarthritis features, which are presence of enthesitis, enthesial inflammation like Achilles tendinosis, or pain on lateral tubercle or medial tubercle. So enthesitis. The other classical is dactylitis, a diffuse swelling of the fingers. There will be diffuse swelling of the fingers due to tenosynovitis of the tendons as well as the interphalangeal joint involvement. So dactylitis, enthesitis, dactylitis, nail involvement, especially in psoriatic arthritis, presence of nail involvement. Then gastrointestinal involvement, like if it is a diarrhea associated or inflammatory bowel disease associated, it is more often seen in spondyloarthritis. So when we go again, it can be single joint involvement, that is monoarthritis, classically seen in septic arthritis, acute first episode or second episode of gout, or oligoarticular. Oligoarticular in some of the features, maybe the first presentation of a polyarticular joint involvement. Otherwise, oligoarticular involvement is seen in Ponsard disease, post-tuberculosis reactive arthritis things. And some of the viral arthritis can also cause an oligo pattern of involvement. Maybe in a chronic kidney disease, the gout may be presenting as an oligoarticular involvement. Juvenile inflammatory arthritis, so immune arthritis, so there can be oligoarticular involvement. Classically, most of the arthritis per se, what we see like rheumatoid arthritis or systemic lupus erythematosus or Sjogren's disease, such things are mostly polyarticular involvement. One important thing is the pattern involvement, additive, migratory, or intermittent. So additive, as I told, a joint is involved. Over that, a new joint involves, and then the other joint and the other joint. They keep on adding up. Classically, is in rheumatoid arthritis. While a migratory thing is one joint improves, but while it is improving, the other joint involves. Classically seen in acute rheumatic fever. It's also seen in some other conditions like sarcoidosis, where you can get a migratory type of involvement. Even in infective endocarditis, you may get a migratory type of joint pain. Classically seen in acute rheumatic fever. Intermittent is you have a joint involvement, the joint subsides, goes to normal, and after some time, a second joint is involved, or the same joint can be involved after some time. In migratory, there will not be a time gap in between, while in intermittent, you will have gap in between. The crystal diseases like gout, you have a first MTP joint involvement, then that subsides, acute podagra, and that subsides, and next day they may have a second, maybe after a month or a few months, they will have an involvement of the next MTP joint or an ankle joint. So that is how intermittent, most classically seen in one classical is crystal disease, the other is something called palindromic rheumatism. Very often seen in our scenarios. We see it a lot, palindromic rheumatism. It's also an intermittent thing, very acute onset, just comes on a morning, they will have an inflamed wrist. It lasts for 2 to 3 days, then it subsides. Sometimes on the same session, you may have another joint involvement, or maybe after some time, the next joint involves, lasts for 2 to 3 days, then subsides and clears. There will not be any pain persisting after that. It will improve after that. So it mimics like a gout or crystal disease, but it is palindromic rheumatism. It is a little different from that of gout. So basically, it is rheumatoid arthritis or a spondyloarthritis. If we can differentiate between, make a pattern like that, it will be easy to manage the patient. But for monoarthritis, obviously, we have to think about septic arthritis, gout. So next is, so we have identified it as inflammatory, chronic or acute, and whether it is an RA pattern of illness or a spondyloarthritis pattern of illness, or if it's an migratory polyarthritis rather than an additive or intermittent, and whether it's an acute thing or a chronic thing, then we need to look for the basic concept in arthritis is look beyond the joint, because that is what is going to help us in making a diagnosis. That will also help us to prognosticate the patient. That will also help us to plan the management. So how is it going to affect? Like already I told, spondyloarthritis, if there is nail involvement, eye involvement, GI tract involvement, which can be picked up. So that will help us in recognizing that it's not just an RA, it is more likely a spondyloarthritis. So what are the things we have to look for? So these are the common connective tissue disorders or autoimmune rheumatic disease that can have arthritis as a predominant symptom or an arthritis as a symptom. And RA is a classical arthritic autoimmune rheumatic disease. And spondyloarthritis, mixed connective tissue disorders. There is something called inflammatory myositis associated with arthritis, especially anti-synthetase syndrome. So, and systemic lupus erythematosus or Sjogren's syndrome, where they have oculo-oral cicca syndrome. So there are so many autoimmune rheumatic diseases, but the domain of involvement, predominant domain of involvement, arthritis are a few, and RA is the most common. So when we look at these autoimmune rheumatic disease where you can get an arthritis as a symptom, if you look at the other like SLE patient, we have photosensitive rash, malar rash, discoid rash, ACLE rash, psoriasiform rashes. So oral and genital ulcers, Behçet disease, we can have arthritis, but they will have oral and genital ulcers. So if you look at Raynaud's phenomenon, some muscle weakness, presence of features of vasculitis like gangrene or a mononeurotis multiplex, and patients involving hematological system involvement like cytopenias as in systemic lupus erythematosus, renal involvement as in vasculitis or SLE. Other systemic symptoms can also help us in diagnosing things. Also, some of the extraarticular manifestations like rheumatoid nodules, which are hard, subcutaneous, less mobile nodules, that also help us to in making a diagnosis. So presence of such an extraarticular manifestations, like if there is an interstitial lung disease, the treatment of maybe a little, not little, it will be different. Or if it is an SLE with arthritis, the management will be very different from a rheumatoid arthritis with just arthritis. So it is very, very important to recognize the extraarticular manifestations of the autoimmune rheumatic disease. It will help us to prognosticate, it will help us to diagnose. It will be the most important thing in planning a treatment protocol. So if you look at this is one common manifestation. So you can have eye manifestations. Rheumatoid arthritis can have scleritis. You can have this is in a hypopyon, and a hypopyon which is seen classically in spondyloarthritis, anterior uveitis, and you have hypopyon. This is a sterile pus in the anterior ocular cavity. So here is a patient with Wegener's disease where they present with arthritis as one manifestations, but you can see the saddle nose as well as the involvement with the scleromalacia and the scleritis. So if we look at this one, this is a skin rash, but skin rash is an psoriatiform skin rash, while here the skin rash is that of an lupus patient with the lupus skin rash. This is also a lupus patient with the classical photosensitive malar rash, and they have erosive acute cutaneous lupus where there is erosive rash. So rash itself may be associated with arthritis, but here we have psoriasis rash, we have lupus rash, or sometimes it may be a myositis rash. So we have a periorbital puffiness as well as periorbital iliyotropic rash. And one classical manifestation is mechanic hands, which is seen in an inflammatory myositis called antisynthetase syndrome, where you have arthritis as a predominant manifestation. Seronegative arthritis, one important cause for a seronegative arthritis is antisynthetase syndrome, where you have systemic symptoms predominant like fever, you can have associated interstitial lung disease, arthritis, and these features like mechanics hand. So this one is an tophaceous gout. It's a gouty tophi, and you can see the crystals oozing out of it. And the same patient X-ray is showing multiple extra marginal erosions, like well-defined punched out erosions extra marginally. While this is a patient with psoriatic arthritis, where you can see the diffuse dactylitis. See, all the digits are so swollen and the nails are so broken. So these are the changes of a dactylitis as well as nail changes. You can also see a sort of edema, dorsal feet edema. Inflammatory dorsal feet edema and dorsal edema can be seen in psoriasis, spondyloarthritis patients as well as in inflammatory myositis patients also. Here is a patient with vasculitis. They have a digital gangrene, and this is an ulnar nerve weakness. So it's a mononeuritis involving ulnar nerve, which suggests that there is a medium vessel involvement. There is a gangrene. You have non-healing punched out ulcers. So classic vasculitic punched out ulcers you can see in vasculitis. So if we can identify classical scleroderma patient, you have salt pepper pigmentation, you have sclerodactyly, you have puffy fingers. So if we can identify such extra-articular manifestations, it straight away gives a diagnosis. So the more diligently we look for extra-articular manifestations, the more we get close to a diagnosis. So if we have features like this, and then going for investigations of rheumatoid factor or anti-CCP, doing for other investigations, ANR, are useless. So if we can just identify a TOFI and with the history of an intermittent joint involvement in a male patient, non-menstruating female, then the chance of it being gout is very high. So identifying extra-articular manifestation is of profound importance in when we approach a patient with joint pain. So is the other manifestation, like if there is a proteinuria with an active urinary sediments in a young female with polyarthritis, the chance of it being a lupus is very high. So we have to identify such things along with approaching a joint pain. It's not just joint, it is actually beyond joints. So most of them, even in rheumatoid arthritis patient, you can have extra-articular manifestations of rheumatoid arthritis like rheumatoid nodules, interstitial lung disease, scleritis, systemic rheumatoid vasculitis. So such things can happen. So when we see a patient with joint pain, we should be tuned to look for things beyond the joints, and that will help you a lot in assessing a joint pain. So epidemiology part, if it's a young female, females are more often affected with autoimmune rheumatic diseases. So young female with systemic features of fever, hair loss, and polyarthritis, the chance of it being lupus is very high. But a relatively middle-aged females or 40s and 50s, typical rheumatoid arthritis pattern of illness, no extra-articular manifestation. So chance of it being rheumatoid arthritis is more likely than lupus is. So age of the patient, sum of the race, family history. Most important is spondyloarthritis. If you have a family history of psoriasis and the index patient is presenting with a knee effusion or an ankle effusion, then the chance of it being in psoriatic arthritis is very high. So you have to look for presence of, ask for family history. It's most important in spondyloarthritis. Presence of ankylosing spondylitis in one of the family members make our diagnosis more straightforward. Presence of HLA-B27 associated diseases in a patient or in presence of IBD in family, it makes our diagnosis more easy and more clearer. So family history is also of very much importance in assessing a joint symptom. So these are the common differential diagnoses for polyarthritis, and we'll just, these are like infections and autoimmune things like but which are being triggered by infection, like a reactive arthritis where you have an infection like a diarrhea or a UTI, and then you have polyarthritis, or acute rheumatic fever, post-streptococcal arthritis, post-streptococcal reactive arthritis, PSRA, or acute rheumatic fever, or like things like a primary arthritis manifestations are in this one. So some of the autoinflammatory disease, especially we see adult onset Still's disease, AOSD, where you can have fever, joint pains, polyarthritis, the typical rash, neutrophilic leukocytosis, lymphoma, splenomegaly, and all. And some of them are non-inflammatory causes for joint pain, like degenerative diseases, metabolic diseases. So another important thing in approaching a patient with polyarthritis is to get the mimickers of polyarthritis. Some of them exactly mimic an arthritis, and we may even think it is an inflammatory arthritis and start treatment. Even if we give steroids for longer, we add methotrexate, we add things like that, disease modifying agent, patient will not improve, we'll change the drug. Actually, basic diagnosis may be wrong. And one most important thing is fibromyalgia. Fibromyalgia is widespread pain disorder. So there is it's a disease where pain sensitization is different. So the patient may feel pain. most often post exercise pains. And this is one important differential. Fibromyalgia is associated with more than 1/3 of most of the autoimmune rheumatic disease. Almost more than 1/3 of patients with autoimmune rheumatic disease will have an associated fibromyalgia. So in a patient with rheumatic disease, it is paramount to importance to diagnose fibromyalgia. Also, in a patient with joint pain, it is just needed to rule out fibromyalgia. Then one important is benign joint hypermobility syndrome. Most often young patients who have joint hypermobility, like they can have the thumb sign positive, they'll have valgus deformities. You know the Baton's criteria to diagnose a benign joint hypermobility syndrome. It's actually very common, especially patients with Marfan syndromes, Ehlers-Danlos syndromes. It may be unrecognized. It's more of an use-related pain. So patient is holding a bag for some time, they will have pain in their shoulders. And the patient is sitting idle for some time, or sitting for a movie or driving a car, and after 2 hours they will have back pain, significant back pain. So if we can identify that it is due to benign joint hypermobility, most of them will be misdiagnosed as an axial spondyloarthritis. So it's very important that in those patients with widespread pain, especially if it is associated with an use-related pain, like if the patient sits with their arm flexed or with some support on with the wrist flexed, they can have pain in wrist. Some of the pain will improve by itself in some in short duration, but some pain may last longer, especially back pain may last long. So identifying it as a mimicker of polyarthritis is important. Endocrinopathies, diabetic ketoarthropathy, and it can present with joint pains, especially wrist and fingers. They may be swollen, they may have pain, but it is likely a diabetic ketoarthropathy. Then thyroid disorders, acromegaly, then degenerative disease like bone mineral metabolic dissociations like osteoporosis. More than 60 years females presenting with significant back pain or generalized body pain, not exactly in the joints, but they will complain of more of a back pain and generalized pains. And neuropathies, metastatic diseases, acute leukemia. In a patient with younger or any patient, acute onset fever, maybe for 2 weeks or 4 weeks, systemic symptoms like B symptoms associated with some rash, joint pains. Acute leukemia is one thing where you have a joint pain which is disproportionate to the joint involved. When you look at the joint, it may not be that much inflamed, as in a patient with the reactive arthritis or a patient with rheumatoid arthritis, where the joints will be swollen and diffusely swollen and painful. Here the pain will be disproportionate, but the swelling or the signs we cannot elicit, but the patient will not allow you to touch. So that is one important thing in relatively acute, less than 4 weeks or less than 6 weeks thing, especially in kids and younger adults. You get acute leukemia as a cause for polyarthritis. And elderly patients, Parkinson's disease is something which the rigidity may be mistaken for joint involvement, joint pain. They have actually marked rigidity. Also that Parkinson's can be associated with some joint pain symptoms, but that marked rigidity may be mistaken for a joint pain. Then one important thing in neuropathy means carpal tunnel syndrome. Carpal tunnel syndrome symptoms may mimic that of a joint involvement, inflammatory joint pain. So that will be more at night, worse with that. So, but the presence of other symptoms may help us to differentiate. So these are important. Most important: fibromyalgia, benign joint hypermobility syndrome, osteoporosis, and endocrinopathies, especially thyroid disorders, are the most important mimickers which you have to think in all patients who are presenting with polyarthritis. So some of them, like a patient presenting with a shoulder pain. So there are some regional pain syndromes which are related to the joint structures around that. So for a shoulder pain, rotator cuff tendinitis, rotator cuff tears, subacromial bursitis, such things. Frozen shoulder in a patient with diabetes mellitus, or referred pain from cardiac referred pain, or in subdiaphragmatic from subdiaphragmatic areas, and wrist especially decurvent tenosynovitis or DQTS, where your extensor tendons due to repeated trauma and repeated use, you may have tenosynovitis of the tendon, but the patient will be complaining of wrist pain. But when you do a finger skin test, you can identify that the pain is more limited to the extensor tendons. So that is important to this one. And diabetes associated trigger fingers. So all these, before making a diagnosis of rheumatoid arthritis, it is always better to rule out local regional pain syndromes, or the previous systemic diseases like fibromyalgia or benign joint hypermobility syndromes. So most important one is shoulder pain. Shoulder pain, rotator cuff tendinosis are the most common cause of shoulder pain. It is not rheumatoid arthritis, it is not CPPD disease, it is rotator cuff tendinosis. Also in knees, prepatellar bursitis, patellar tendinosis, mechanical Achilles tendinosis. The patients presenting with heel pain. Heel pain is one, the spondyloarthritis is one thing where you can get heel pain because of the tendinosis. But the most important cause for an heel pain is mechanical. It may be a recent shoe change. It may be a faulty walking. It may be the use of a new shoe, or they may have started just walking newly, or it may be a rapid weight gain they have. So all these structures are, all these things can cause significant heel pain. So it need not necessarily a peripheral spondyloarthritis that is causing the heel pain. So it is very important. Achilles tendinitis. Achilles pain can be due to a faulty shoe, a new shoe where you can have, or maybe the patient had gone for a pilgrimage. They have walked so much and they are coming back with a heel pain or an Achilles tendon pain. So it is better to identify these regional pain syndromes before labeling them as peripheral spondyloarthritis or an inflammatory arthritis, giving them steroids or any such treatment. So how will you do in history part, we have detailed the things we have to look for in history. So when we go for a physical examination, first and foremost, whether it is an articular pain, we have to, this swelling, we have to examine tenderness, whether it is along the tenderloin, or if it's along the tendons, which causes tenosynovitis, and what range of motions are involved, presence of crepitus, is there a deformity, and if it is unstable, is there any instability we can elicit, and look for the other juxtaarticular structures like the nerve bundles and the tendons around it, bursas around it. And one important thing is, unless you measure it, you can't cut it. Like if you know if you can record the observation, like the quantum of the involvement using a number of swollen joints or number of tender joints, it will be easy for you to assess the response. If the patient comes back, you have started some sort of treatment, and if the patient comes back to you, if you reassess again with the counting the joints, then it will be more easy to say, okay, the patient has this much improvement in. You can also use patient global assessment. Just ask the patient to measure, to give a number between 0 to 10 to tell what is her current status. Every time, okay, 10 is extreme pain, they are not able to do any of the things, 0 is as normal as normal. So if you can get a number in between, you can use that one, or you can yourself do an evaluator global assessment. So it is important to measure the disease so that we can follow up the patient. And then in physical examination, you have to look for extra-articular manifestations, which I have already mentioned. Most important thing is interstitial lung disease, presence of spondyloarthritis features, and oculo-oral sicca. Sjogren's syndrome is one common cause which is often missed in patients with arthritis. They may be rheumatoid factor positive, they will have features exactly that of an rheumatoid arthritis, but there will be significant oculo-oral sicca. There may be some parotid swelling previously, so that may be missed very often. So you have to look for this. ocular sicca, you have to look for any Raynaud's phenomenon, you have to look for systemic features like fever, loss of weight, loss of appetite, interstitial lung disease, other spondyloarthritis features like nail involvement, dactylitis, enthesitis and all. So look for extra-articular manifestations. And investigations are of the least important thing in patients with polyarthritis actually. So we are giving so much importance to investigations. Any investigation should be based on three things. One is, what is the pre-test probability of the disease? If you think the chance of lupus is likely, like if a female patient, young female, who is presenting with some systemic symptoms, some rash, and she has polyarthritis, the chance of it being systemic lupus erythematosus is high. In that context, if you do an ANA, the chance of it being getting positive is high. So, but in a male patient who has presented with the spondyloarthritis-like features, like they have a large joint arthritis, significant enthesitis, inflammatory back pain, the pre-test probability of it is very low. So there is no point in doing an ANA test in such patients. So it should be based on, first one is pre-test probability, which is most important thing. The second one is it will it help in prognosticating or assessing the severity of the illness? The third thing is it going to change the way I manage things? So if the answer to everything is no, there is no point in doing that blood test or any investigation for that matter. So usually any patient with polyarthritis, once we recognize it as inflammatory, even ESR and C-reactive proteins can help us to pinpoint, like more refine our diagnosis of an inflammatory arthritis. See, a fibromyalgia patient, it will be very difficult for us to diagnose a fibromyalgia. It is very difficult actually, or benign joint hypermobility. But presence of a normal inflammatory markers, ESR and CRP, and if our pre-investigation chance for fibromyalgia seems higher, then the chance of it being a non-inflammatory arthritis is high. So, and a basic investigations like a complete blood count, like if it is an hematological involvement, patient with polyarthritis, young female, you have a thrombocytopenia or you have a lymphocytopenia. So the chance of it being a systemic disorder like a systemic lupus is high. So CBC must be done. Also, pre-disease modifying agent treatment starting, we need to have we need to have a general assessment of the patient. So CBC is one important thing. Creat is very important. One actually misinterpreted investigation is uric acid. So hyperuricemia is very common. It's a part of metabolic syndrome. Those patients who are obese, patients with pre-diabetes, patients with dyslipidemia, the chance of them having an elevated uric acid level is very high. So unless you have a feature to suggest an uric acid related disease, like the patient is presenting with an intermittent arthritis, podagra-like episodes, oligoarticular or a monoarticular recurrent symptoms, or a patient presenting with bursitis, you go for uric acid testing. If it is high, the chance of it being uric acid related or crystal related is high. But otherwise, for every joint pain, just presenting with heel pain, we can see so many of them doing a uric acid, and you can see because the heel pain per se was due to an obese patient. Obesity may be the most important thing for heel pain. So they may have a uric acid elevation because of the metabolic syndrome they have. And we will attribute everything that uric acid, they will get febuxostat, they will get things which are actually unnecessary. So think before doing any test. And a liver function test. Creat involvement, like if creat is elevated, that we have to modify our drugs, we have to avoid giving NSAIDs, we may have to dose reduce. If creat is involved, we may have to look for systemic diseases like lupus or vasculitic processes, such things, or amyloidosis and such things. So liver function test, normal LFTs, and involvement like other alkaline phosphatase elevations, or sometimes it may help us to maybe refine our diagnosis. Otherwise, it is very much necessary that we get a baseline SGOT, SGPT before we start disease modifying agents. ESR and CRP. CRP is more refined. ESR is affected by multifactorial things like age, sex, presence of anemia and all. So CRP is more early to rise and more early to fall with the treatment. So CRP is one, it is more costly, that's an issue. But otherwise, CRP will be, it seems a little better option than ESR, but ESR is more cheaper and easily available. And then a urine routine examination is necessary in all patients with, at the first visit itself, in all patients with arthritis. Proteinuria is an alarming symptom. You have to look for especially systemic feature like lupus erythematosus, or it may be an undiagnosed arthritis with maybe amyloidosis, or maybe an extra-articular manifestation like a membranous glomerulonephritis in a patient with rheumatoid arthritis. So urine routine examination at first is very important, and blood sugar examinations. Most often diabetes may be missed, or maybe we are going to plan to start a bridging of steroids, and the presence of an borderline values may be important, because on follow we may have to be more careful for the development of steroid induced diabetes later on. So CBC, creat, liver function test, urine routine and RBS. Calcium, phosphorus, if you think hypercalcemia or anything that is related to hypercalcium, calcium level, elevated calcium levels as in multiple myeloma or a malignancy, such things, if you are suspecting, you can do calcium levels. Or if you think it is a vitamin D deficiencies, it's better that you treat them. Most of the, if you test for vitamin D, most of the Indians will be vitamin D deficient, but it is practically not useful for checking vitamin D deficiency in all patients with just generalized pains and aches and pains. Just give vitamin D for 4 weeks, and then you treat T for the response. That will be a more. So uric acid, vitamin D, and ASO titer. These are the three most utilized, actually useless things. I should say that's an very much over hyped thing. So that we can avoid actually: uric acid, vitamin D levels checking, and ASO titer. ASO titer is elevated in acute rheumatic fever or post-streptococcal reactive arthritis. So if you have features to suggest, if the pretest probability is high, you are not expecting it to be in a patient, elderly patient or a middle-aged adult. Usually acute rheumatic fever is a disease of the young adults. It can still present later on, but usually it will be that of a young adults. And one value of an ASO is not useful. It is the follow-up rising titer which says that you had a streptococcal infection. It just says you had a streptococcal infection. So it is the rising titer. So once an ASO titer is high, that doesn't add to any of your diagnosis. So the chance of it being in streptococcal related is very low. Very less often only we see acute rheumatic fever in an elderly patient or middle-aged patient. So you have to utilize it very, it should be careful when we order a test. ASO will be positive. Streptococcal pharyngitis is a very common disease. Most of us had this one. So if we check for things, they may be just 240, 210, just above that. When the patient will be so worried about that, okay, they have got a high ASO and high ASO. So that is one thing which is which should not be done. And the other one is rheumatoid factor. I'm saying again, it is rheumatoid factor. It is not RA factor, because it's not synonymous with rheumatoid arthritis. It may be positive in around 70 to 75% of rheumatoid arthritis patient, 70 to 75% of rheumatoid arthritis patient, but it can be positive in most other autoimmune rheumatic diseases. In Sjogren's, it may be up to 30 to 40% of the patient can have rheumatoid factor positivity. So it is not RA factor. Presence of a positive rheumatoid factor is not synonymous with rheumatoid arthritis. But in a background of a patient whom you are suspecting rheumatoid arthritis, presence of a positive rheumatoid factor will refine your diagnosis. It also helps us to prognosticate the presence of high rheumatoid factor titers and presence of both CCP and RF factor positivities prognostic significance also. But just mere presence of rheumatoid factor, even in if you do the serology of normal healthy females, you can get up to in around 10 to 15% of them will have a rheumatoid factor positivity. So if your pre-test probability is very low, if you do a test, you will have high risk of false positivity, and you will not know what to do with that positive test. So don't order a test if you are not sure of like, why am I doing it? So that should be clear, because we have seen so many ANA positivity and referred to OPDs because they have an ANA positivity. Why did we do that? No idea. The patient obviously has a psoriasis. Patient has a joint symptoms suggestive of an psoriatic arthritis, but we do an ANA. The chance of it, the pretest probability is very low. And if we get an ANA positivity there, it is high likely it is false positive. So it loses, patient loses money, patient loses mental peace. ANA is positive means they will equate it to lupus. So the mental peace of having a positive ANA is very high. So we have to be very careful when we order investigation. Sorry. And other investigations, anti-CCP, it is a costlier investigation. So if you have a clear-cut arthritis patient, and if you think it is rheumatoid arthritis, you need not go for an CCP. CCP has prognostic value also, but definitely it is. It may not be cost effective. You can just start treating the patient. But if you have extra articular manifestations, and if you think CCP is very specific, the specificity is around 95%. So if you have a CCP positivity, the chance of it being in rheumatoid arthritis is very high than a patient who have just a rheumatoid factor positivity. So in that way, you can refine your diagnosis of rheumatoid arthritis. But if you have a straightforward case of rheumatoid arthritis, and RF positivity is good enough to start treating the patient. ANA is only indicated if you think the chance of it being an autoimmune rheumatic disease where you can get an ANA positivity. It is not just equating to lupus. You can get ANA positivity in Sjogren's disease. You can get ANA positive in mixed connective tissue diseases. You can get ANA positive in many other autoimmune rheumatic diseases, including myositis. So you should know what sort of connective tissue disorder I am expecting, and then order an ANA. If you have features of this one and an ANA positivity, and if you think it's a connective tissue disease highly, then you can go for ANA. Is usually done by immunofluorescence. It is a screening test. ANA by immunofluorescence is a screening test. So we have to know which antibody we are checking for. So for that, you can do an, it's called ANA profile, which will include multiple cytoplasmic or nuclear antigens, and we will get which antibody is positive in our index patient. That positivity may help us to refine our diagnosis. Presence of dsDNAs, anti-Smith is more suggestive of lupus. Presence of Rho positivity, La positivity is more likely a Sjogren's disease. UNRNP positivity is mixed connective tissue disorder, SCL70 with scleroderma, so on and so forth. So presence of ANA, it doesn't stop there. So if your pretest probability for a connective tissue disease is high, because you have features of connective tissue disease other than arthritis, and you get an ANA positive, then look for the specific antibody. Otherwise, if you have just an antibody ANA positivity and you have an arthritis, you don't have any other extra articular manifestations, it is better not to go for an ANA profile. One ANA profile is around 1,500 rupees. You can treat that patient for 6 months with that 1,500 rupees. So think before sending an ANA and ANA profile. If you are suspecting vasculitis, go for vasculitis markers and axial symptoms. If you have an axial spondyloarthritis or a peripheral spondyloarthritis, presence of HLA-B27 will help us to refine our diagnosis. Every time I am using the term refine our diagnosis. So it is not that the diagnosis is already made. You have a patient whom you have diagnosed it as axial spondyloarthritis, or you are diagnosed it as peripheral spondyloarthritis. Presence of HLA-B27 will reaffirm your diagnosis. It will also help us to prognosticate, because the chance of it being chronicity to run in family is high. So it is better always to get an viral markers screened, especially if you think the risk factor, if there are risk factors for hepatitis B, C, or HIV, because all of this can have joint manifestations as a clinical symptom. Also, multiple extra-articular manifestations are like gangrenes or skin manifestations, which may mimic and connective tissue disease high with hepatitis B positivity or hepatitis C positivity or HIV. Also, presence of such things will alter our management policies. If we have to add an immunosuppressive treatment, you need to treat all patients with hepatitis B or hepatitis C or HIV before we start the patient on immunosuppressive treatments, especially cyclophosphamide or mycophenolate mofetil or rituximab if you are giving, or biological drugs if you are giving. You need to rule out such things and treat them, and then you have to start treatment. TSH, a thyroid screen, just a full panel is not needed. You can just use just a TSH screen, and then based on that screening, you can go for full free total T3, total T4. If you suspect hypothyroidism as a cause for the joint symptoms, you should have other clinical features corroborating with the hypothyroidism. Then, as I said, calcium profile also. So CBC, RFT, LFT, urine routine RBS, ESR, and possibly CRP, and a rheumatoid factor. This should be done in all patients, and a chest X-ray. So a synovial fluid assessment. Synovial fluid assessment will help us in infection, septic arthritis. You will get past, you go do a gram stain, or if you think it is a tubercular, you just do for an PCR. And if you are thinking it is gout or a CPPD, you can get crystals in that. Otherwise, in routinely, synovial fluid assessment is not needed, and it will not help us in any way, especially in rheumatoid arthritis or in other patients, psoriatic. It will not help us anyway. An X-ray, chest X-ray is important. Chest X-ray should be done in all patients with polyarthritis. It helps us in, first one is it helps us in diagnosis. If it is a tuberculosis with a Ponsett disease or a sarcoidosis patient, you can get the hilar lymph nodes. Also, it will help us to know the complications, like if the patient has already interstitial lung disease, or if you have pleural effusion, you can diagnose it. So as a diagnostic part also it is important, as well as in a treatment part also, assessing the disease severity as well as the treatment part. If there is ILD, we may not be going for methotrexate upfront, and we may avoid some of the treatments, thinking that it may worsen the interstitial lung. So chest X-ray is very important. Should we go for an X-ray of involved joint? If it's a clear-cut, straightforward case, you may avoid it. But if you think between a polyarticular gout versus a rheumatoid arthritis, you can go for an X-ray. You may get some features which more suggest an gouty arthritis than rheumatoid arthritis. And if you think it's a fibromyalgia versus rheumatoid arthritis, you may go for an X-ray and see whether there are erosions or periarticular osteopenia, which has not seen in fibromyalgia or benign joint hypermobility syndrome. So you can, for example, Charcot joint, it may help you. A radiography of the involved joint may help us. And if the patient has axial symptoms, joint imaging and sacroiliac joint may help us. So X-ray, chest X-ray is very important. Involved joint, yes, it is important, but you can avoid it. And an ultrasound examination for the, it's very important actually, ultrasound examination. It can show us crystals in gouty diseases. It can help us to differentiate between inflammatory and non-inflammatory pain. It will show us the joint effusions in inflammatory pains. And it may also help us in diagnosing erosions in rheumatoid arthritis. If you see an effusion with an erosion, it straight away says that it is an inflammatory. You have to consider it as an inflammatory arthritis itself. MRI is most often not needed, but if you have a shoulder pain which you suspect that it may be a non-articular, but you are not sure of it, and if you want to rule out things, you may get an MRI done. That will help you to soft tissue, specifically not just joint. It is more important for the periarticular soft tissue involvement, bursitis, the tendon ruptures, tendinosis, and other things. So it may help you in making a proper diagnosis, even in assessing for the disease severity and all. But usually in a normal, just a joint pain cases, we don't get an MRI done. So what about treatment? Treatment is based on the basic cause for the arthritis. The diagnosis like rheumatoid arthritis is treated in different way than systemic lupus erythematosus, and spondyloarthritis may be differently treated. And it also depends on the organ involvement, domain involvement, whether there is an lung involvement, whether there is significant axial involvement, GI involvement. So there are so many factors which we consider before making a treatment plan for the patient. But so far, common polyarthritis, just polyarthritis, no other extraarticular manifestations. We can start with treatment with the disease. Almost all the inflammatory joint pains will need conventional synthetic disease modifying anti-rheumatic drugs. Almost all, because if you treat early, the chance of achieving a remission is high. Also, the chance of preventing damage is very high. So it's always better to start disease modifying anti-rheumatic diseases upfront in all patients with inflammatory arthritis. So once you have a straightforward case, you can just the anchor drug and the most important drug is methotrexate. Sorry, is methotrexate. You can start with 10 mg per week. Sometimes if it's a young patient and all, we can even start with 50 milligram per week. You need to have a baseline CBC, SGOT, PT, and creatinine, and a chest X-ray. If possible, a viral markers if the risk factors are high. And you can start treatment with methotrexate. Leflunomide, you have to be very careful in those patients who are planning for pregnancy and all. Sulfasalazine or hydroxychloroquine. Methotrexate is the most important thing. Leflunomide and sulfasalazine are almost equally effective as methotrexate, but hydroxychloroquine is not a very good disease modifying drug. But if you have a mild disease, you can just start hydroxychloroquine and see. If not responding, you can add to methotrexate. It's always methotrexate is always the first choice of drug for a rheumatic disease. Then other drugs like biological disease modifying agents, targeted synthetic disease modifying agents like tofacitinib are based on usually for refractory diseases not responding to methotrexate. So the pre-initiation workup is little different. The post-initiation workup and follow-up are different for most of the different biological disease modifying agents. It's beyond the scope of the topic, so I am not going into that. We can use a steroid as a bridge therapy. So most of the disease modifying agents, especially methotrexate, will take 6 weeks to 8 weeks to act. So most of them will take much time. So to bridge that and to have it, steroid is the most potent anti-inflammatory thing. So it will help us to have an acute effect, and also it will help us to hold the inflammation till the effect of the disease modifying agent starts. So, but prolonged steroid use obviously will have so many issues. One thing is steroid-induced side effects like diabetes, osteoporosis, hypertension, then proximal muscle weaknesses, peptic ulcer diseases. Also, it is very difficult for you to taper off the drugs if you are continuing the patient on steroid dose. So the one thing is recent studies suggest that if low dose steroid is 5 or less, 5 mg Visulon or less, prednisolone 5 milligram or less, you can use for little longer. But it is always better to control the disease with disease modifying agents and reduce the steroid dose as low as possible. But if the patient is very much symptom free with an Visulon of 2.5 milligram daily or 5 milligram alternate day or even 5 milligram OD, and if you have to add leflunomide 20 milligram, hydroxychloroquine to 200 milligram, or if you want to add an tofacitinib, so that you can reduce the steroid dose to 0 or make the patient steroid free, then that may not be that much cost effective. So cost is one important thing when we consider a treatment option, but it is always better that you bring down the steroid dose as low as possible, as fast as possible. So it's always better that you give a short course, like if you give prednisolone 5 milligram BD for 10 days and then reduce it to 5 milligram OD for 10 days and then just stop with the treatment, steroid just to try. If the disease burden is not that high and all, you can just reduce the steroid faster. Or you can just give an depot steroid drugs like a depomedrol or Kenacort 40 milligram on the first instance you see. And then you start the disease modifying agent and give analgesics on SOS basis. Sometimes that works actually. So you may able to get the patient off steroid very fast. So you can try all those things, but keeping a patient on low dose steroid like 2.5 milligram or 5 milligram alternate is also acceptable, given that you have to add so many other drugs so that you can get to this steroid free thing. You have to add the cost benefit also to that. Other pain relief measures and analgesics SOS basis and other topical ice therapy and all you can consider. Sometimes it may worsen the patient, so be careful. You have to tell them. Sometimes heat works, most often heat works, cold worsens, but sometimes even in gout and all, cold is better actually. And physical rehabilitation, damage, some of them are permanent damage. You may have to help the patients with the physical rehabilitation. You may have to go for a knee replacement or hip replacement and such things. So physical rehabilitation, you should start from the first episode itself actually. That will help us, the patient, in improving the outcome. So to conclude the session, we have few take-home messages. Most important, identify the pattern of involvement, whether it is in rheumatoid arthritis pattern or a spondyloarthritis pattern. That will help you a lot. Look beyond the joints for extraarticular manifestations. Look beyond the joints for extraarticular manifestations. If you can identify them, that will help you a lot. Be careful for mimics, especially fibromyalgia, benign joint hypermobility, hypothyroidism, diabetes related. So be careful for mimics. Measure the disease before managing. You should not use rheumatoid factor or CCP titer. You have to use tender joint count, swollen joint count. Getting an rheumatoid factor every visit is not needed. It doesn't help you anyway. Only in first initial diagnosis and prognostication, the rheumatoid factor and the CCP helps. So you shouldn't use these things to measure the disease before managing. RF positivity is not equivalent to rheumatoid arthritis. RF positivity is not equivalent to rheumatoid arthritis. And for all the cases, use your investigations judiciously. It is your initial clinical manifestations, presentations, your examination findings, which will help you in making a more likely diagnosis and support your investigations to refine your diagnosis, to assess for the extent of the disease, and to start the drug treatment. ASO titer, uric acid, and vitamin D. These things are, please be judicious in their use. Most often it is not needed. Most often it is not needed. So you have to be careful because it's not cost effective. That it brings so much cost and mental trauma to the patient. Presence of ASO positivity, and the patient will keep on going for things. So be very careful before ordering an investigation in a patient with autoimmune rheumatic disease. So thank you all, and I will be ready to take few questions if the moderator allows.
Thank you, Dr. Adarsh. Thank you for that very informative session. If anyone wants to ask any doubts, kindly send SMS.
Okay, I have chats.
We have a question, Dr. Adarsh. For how many days steroids can be used as bridge therapy by Dr. Mohammed Sufi
So
Sujail?
usually bridge therapy is till the disease modifying agents act. So most of the guidelines say to keep it less than 3 months, but sometimes it's not possible always, but definitely bring back to a smallest possible dose. The bridge treatment is usually 3 months.
Okay, thank you. Dr. Mamta has a question. Which DMRDs can be safely started in primary care?
So hydroxychloroquine usually won't have much adverse events in primary care. You can start methotrexate. Methotrexate is not that bad drug actually. If you have an CBC with you and then SGOT-PT, then you can, and a creat within limits, you can start methotrexate at 10 milligram per week. And just to repeat this CBC and SGPT at 6 weeks or 8 weeks, or after every time you raise the dose, hike the dose. If you have to go beyond some 15 milligram, or you have to add other drugs, then it is better that you keep a close follow-up for the patient. Otherwise, methotrexate is okay. Sulfasalazine is a safer drug. Only thing is that you have to just tell the patient to stop the drug if they develop any rash or diarrhea or any allergic symptoms. So steroids are okay. Steroids also you can start, but be careful, patients, because the prednisolone tablet is very cheap, so they will get addicted. You can't just stop that. So you have to be little careful in giving steroid therapies. Most other, you may in primary care better to that biological disease modifying agents and tofacitinib and all, it is better not to start from primary care, because sometimes we may have to reassess the patient whether that the diagnosis of rheumatoid arthritis itself is correct, or we may have to change the diagnosis. We may have to know why the patient is not working on first line disease modifying agents. So other things, it is better that be cared by a specialist. Otherwise, all the other drugs you can start in primary care.
One more question from Dr. Sufi Sujait. Most of the cases of rheumatoid RF cases of rheumatoid factor are negative, but symptoms are of rheumatoid arthritis. How can we proceed?
So we level like rheumatoid factor can be positive in up to 70. Usually sensitivity is around 70 to 75. So it can be negative in up to 30% of the patients. And anti-CCP is also like positive in around 70 to 75% of the patients. So we may just, if RF is negative and if you still think this is rheumatoid arthritis, you can go for a anti-CCP. If it is positive, well and good. If both are negative, just reconsider your diagnosis. It need not necessarily rheumatoid arthritis. Sometimes it may be a psoriatic arthritis. Look for psoriatic rash. It may be an systemic lupus erythematosus, or it may be a CKD patient with polyarticular gout, or maybe palindromic rheumatisms, or something else, or maybe not inflammatory at all. So all seronegative patients, you should consider your diagnosis. You check for other manifestations out, and if you think that nothing is there, still it can be rheumatoid arthritis. You can, if it is an arthritis predominant disease, you just treat it as rheumatoid arthritis. You can start disease modifying agents and look for the response. So it's not, the treatment is not necessarily be based on the label we give. If you have just an arthritis, and if you don't have any other much symptoms, you can just treat it as an inflammatory arthritis with the disease modifying agents. That's okay. You can label it as seronegative. Once you see a patient with seronegative label, just think about beyond rheumatoid arthritis. Actually, that is the most important thing.
Okay, what is the drug of choice in pregnancy?
So pregnancy things safe are sulfasalazine, hydroxychloroquine, and steroids. So patients usually, if they are planning for pregnancy, ideally methotrexate should be stopped for at minimum of 3 months. And leflunomide washout should be given for patients who are on leflunomide, or at least 2 years actually leflunomide. So ideally better not to start leflunomide for patients who at least who they are planning for pregnancy. It's always better not to start. And it's always better to document that when you start methotrexate and leflunomide, you have explained the carcinogenic, teratogenic effect of the drug to the patient, and advice to contraception. It's always, if the patient is married, you just document that the patient has been explained about the teratogenic effects and advice to contraception accordingly. So that will help you legally also.
Okay.
Even
And
if the patient is on methotrexate, gets pregnant, most often you don't have to just terminate the pregnancy, and you don't have to be panic at all. The chance of them having an neural tube defect is actually very low. It's not that every patient who are on methotrexate, if they get pregnant, will have a bad pregnancy outcome. Is not correct. So you can explain them there is a risk which is higher than normal, and if they want to continue with the pregnancy, well and good, you can just continue with the pregnancy and closely monitor them for any development of any neural tube abnormalities or any any such effects.
Okay, thank you. One question from Dr. Devanand. Tophaceous gout with normal uric acid, should we give hyperuricemic drugs?
Okay. So the thing is, usually in acute episodes, there may be the uric acid may be low or normal. Most of them will be consumed within that acute podagra thing. So uric acid can be pretty normal during acute. So usually we don't advocate using testing for uric acid in acute gouty attack or acute inflammatory thing. It is during the interictal phase that we do uric acid levels. Even the target for uric acid is in normal patients, it is less than, to keep the patients under less than 6. So if you can achieve that 6, one thing, if repeatedly if your uric acid is in interictal phase is normal, then reconsider the diagnosis of gout. So if it is proven gout and the uric acid levels are within limits, it's very less likely that such thing happen. But it's always better that you start them on low dose urate lowering therapy and maintain that levels under 6.
Okay. One question from Dr. Medmaniac. I don't know who's that. If a patient is planned for elective surgery, is it necessary to stop DMARDs? If so, how earlier should we stop? For common drugs like methotrexate, hydroxychloroquine, leflunomide, and steroids.
So it need not be stopped. The current recommendation is that you continue with the disease modifying anti-rheumatic drugs, because the chance of having a flare is very high when compared to having a the most important problem is post-op infection risk. So the chance of post-op infection risk is very less and the chance of flare is very high. So the recommendation is to continue with the disease modifying agent. And if the dose is very high, like methotrexate 25 milligram, you can reduce it to 15 milligram. But the current recommendation is continue the drugs. And never ever stop the steroid dose all on a sudden. That is more often seen. Patients are planned for total knee replacement. They will stop all the drugs, including steroids, and the patient will develop acute adrenal crisis, post-op hypotension and all. Everyone will treat it as sepsis, but definitely it was just an steroid withdrawal or Addison's crisis. So you have to continue with the disease modifying agents.
Okay. One more question in rheumatoid arthritis. How to titrate methotrexate doses during OP follow-up visits? When should we increase doses? By how much? And what is the maximum dose?
So usually methotrexate, we start at 15 milligram or 10 milligram. More than 60 years, we usually start at 10 milligrams. Otherwise, young patient, we can even start 15. But maybe in periphery, better to start 10 milligram and monitor CBC and SGPT. Immediately after starting, it is better to follow up after 6 weeks. Check as CBC and SGPT. If they are within normal limit, you can hike 5 milligram every visit, or even every 2 weeks. The recommendation is you can start rising every 2 weeks to maximum dose of 25 milligram per week. What we usually do is first initial things, maybe we will call them patient in 4 to 6 weeks time, 1 or 2 visits. After that, once we stabilize the patient, we will months. And the investigations need be repeated only at 3 or 4 months. CBC and SGPT may be repeated every 3 months. Recommendation is for every 3 months. And after every hike in methotrexate dose, or adding a new drug like a leflunomide. And creatine maybe every 6 monthly or yearly once.
Okay. Dr. Limnu has asked, any role for NSAIDs?
Yes, definitely we have, because I already told there is a bridge gap between the onset of the action for disease modifying agents. So it's all, NSAIDs are a very good drug for pain relief. So you can consider, but in axial spondyloarthritis, the treatment itself is NSAIDs. If the patient is not responding to NSAIDs only, we will go for disease modifying agent in axial spondyloarthritis. So NSAID has a role, but when you give it along steroid, the chance of them developing peptic ulcer disease is high. So steroid alone, you don't have to give Randac or pantoprazole, but if you give an NSAIDs along with that, it is better that you give PPI or H2 blockers. And chance of chronic acute kidney injury, what they say is if the baseline creatinine is normal, the chance of developing acute kidney injury is less. But of course, we do see many rise in creatinine and interstitial nephritis with disease NSAID. So it's always better to be careful. There is no choice of NSAIDs. We can choose any of the NSAIDs. The risk of renal injury is almost same with almost others, and pain relief is also almost equal, aceclo, diclo, or naproxen or etoricoxib. Etoricoxib and other selective coxibs are more intestine safe. That's only advantage. Otherwise, you can just use any of those drugs. And Deflaza versus other steroids. Deflazacort, that's an important question because Deflaza is very costly. Very costly in the sense you may have around 8-9 rupees up to 10 rupees sometimes, but prednisolone you can get in 1 rupee thing. So they say that some of the adverse effects of steroid use, especially the Cushingoid appearances, the buffalo neck hum and all those things, and facial hair hirsutism are less with the Deflazacort. But only limited studies. Most says that both are equally effective as well as equally the adverse events profiles are also equally normal. But what we see is more often that Cushingoid appearance is well. So give low dose prednisolone. That will not cause that much Cushingoid symptoms. So that is one. Deflazacort is very costly. Cost effective versus prednisolone is an issue. 6 mg Deflazacort is equal to Visolon 5 mg.
Okay, Dr. Vijay Matthew has asked, is it common to have ophthalmological complications of HCQS? I think he meant how common is it to have ophthalmological complications?
So it's a dose related thing. It's not an idiosyncratic thing. So if the total dose is cumulative dose is more than 1 gram, then 1000 grams, the chance of HCQ toxicity is higher. So, and it is higher in those patients who have an baseline retinal abnormalities like a diabetic retinopathy or such things. So the recommendation says to do a baseline ophthalmological screening with perimetry and proper fundus, dilated fundus examination within 1 year of starting hydroxychloroquine. Not that before starting, within 1 year of starting, you can do. If there is any underlying retinal disease, it is better to avoid hydroxychloroquine in such patients. And after 5 years, you have to monitor every year with the screening for HCQ toxicity. After 5 years, the chance of risk of HCQ toxicity is higher. And it is an irreversible loss. So it's always better that you screen after 5 years of use. Every year, screen for HCQ related toxicity. Okay, HCQ is not an, it's an mild immunomodulator. So you can stop that. That won't be a much issue actually, unless it is a lupus patient where we are so much for continuing HCQ. It's very useful in lupus patient.
The risk is when it is given more than 1000 mg per day. Am I right?
No, 5 mg per day is the maximum. Current recommendation is 5 mg per day. Previously, it was 6.5 mg per kg. Current recommendation for dose is 5 milligram per kg. So we usually give 200 to 300 milligram per day. So total cumulative dose of 1000 grams. Cumulative dose, you give it for 1000 days or 3000 to 1500 days, then it reaches almost 1000 grams. So the chance of retinal toxicity is around 20% if you are giving it for more than 5 years, and the chance increase 10% if it is more than 5 years, and it increases to 20 to 30% if the duration is more than 10 years. So it's a dose dependent one.
Okay. Dr. Amrita has asked, how can we decide to add on a DMRD or change one?
So the guidelines suggest adding a disease modifying agent, not changing the disease. If you have patient is on methotrexate, if the patient is not responding, you can add hydroxychloroquine or leflunomide or sulfasalazine. So it's always add-on. Therapy is add-on. But when you give multiple drugs, the chance of adverse events are more, so you need to be a little more cautious. So the usual policy is to make the methotrexate monotherapy to the maximum tolerable dose, which is usually maximum 25, and then add on other drugs. Sometimes we may even go 15 milligram and then add hydroxychloroquine or leflunomide 10 milligram, then high kit to leflunomide 20 milligram, such that. So it's always an add-on. You don't have to change methotrexate to leflunomide.
Dr. Matthews has asked how to safely taper off the steroid-dependent patient, for instance, over-the-counter methylprednisolone use for years. How long should we wait to taper after starting DMARDs?
So one thing is, it's very difficult to taper off steroid in a patient who are taking over-the-counter steroid use. So the thing is, you should be very slow on tapering. That is the one most important thing. If the patient is on 5 milligram prednisolone for very longer period, you taper it to like take 5 milligram on one day, 2.5 milligram on the other day. For 1 month, you continue 5, 2.5 alternate. Then you make it 2.5 milligram OD. Then you make it 2.5 milligram. 1 month after that, you make it 2.5 milligram alternate day. And then maybe a third day or fourth day, and then stop. 2 in a week. Like that, you have to go over a period of monthly. Very slowly, you have to go.
Okay.
And
I think we are...
even if you start disease modifying agent, it's very difficult to taper off steroids once they are dependent. But definitely you can motivate the patient, because most often it is not the arthritis, it is the feeling of well-being that they lost. Because steroid gives them a feeling of well-being. So if you go very slow, motivate the patient, then you may get them off the steroids.
Okay. I think we are running short of time. We'll take one last question is there. I think that has been discussed before. Which oral steroid gives the best result? Can we use other steroids like Deflazacort?
The thing is same. I said Deflazacort has some added advantage, so-called added advantage, but most often we do use. But the chance of Cushing or habitus and less with Deflazacort.
Thank you, Dr. Adarsh, for this wonderful session. Over to the coordinators.
Thank you so much, sir. We in AFPI are really privileged to have you in our session. I'm sure every participant are really thrilled and have been enlightened by your session, sir. And now I invite Dr. Nigesh to give out the vote of thanks.
Thank you, Navina. Thank you, sir. That was very nice and an informative session. And you have made a vast topic of arthritis look like very simple. As said, arthritis, it is not just a joint pain. It is not just a pain in the joint. It can be a manifestation of other disease, can be other disease also. So you have explained that in a very detailed and very understandable manner. Thank you, sir. Thank you for being with us in your busy schedule, taking time to make us understand about the topic. Thank you, Dr. Adarsh. And I also thank Dr. Anand, family physician. He's a senior family physician. And thank in the name of myself and in the name of FPI Kerala North Zone chapter. Thank you very much, sir. And I also thank Dr. Prashov, President FPI North Zone. Also thank Dr. Navina, Dr. Vijay Raj, sir, Founder President of FPI. And also I thank all the participants, those who have participated today. Thank you.
Thank you all. Thank you so much. It was nice being with you all.
So shall we end the session, sir, Dr. Prashov?
Yeah, we
Yes,
can
yes.
stop.
We can stop.
So see you all in next academic session. Bye for now. Thank you.